movements are restricted. Any movement of the body is restricted to joints. Joints are what move. Okay. Joints are called articulations, where bones meet one another or muscles meet one another. They exist where two or more bones meet. Those are joints. Okay. Bones may be in direct contact or separated by fibrous tissue, cartilage, or fluid. Remember we talked about synovial joints, like in the TMJ in your elbow. We talked about the vertebrae in your back, separated by cartilaginous pads. Okay. And we talked about the intramembranous membrane connecting out the ulnar and the radius in the arm. Same with the tibia and the fibula. Those are fibrous tissues. Okay. So joints are classified based on function and structure. The function is the range of motion, how far you can rotate joints. Structure was what makes up a joint. So we're going to classify our joints based on how they move, what kind of function they have, and what makes them up, what composes them. Okay? So joints can be classified on the range of motion. There's three different types. There's synarthrosis, which is an immovable joint. There's amphiarthrosis, which is slightly movable joint. And there's diarthrosis, which is a freely movable joint. Okay? Who can think of an immovable joint?
The sutures in the skull.
Those are the sutures of the skull. Those bones come together, and those are immovable. Those are synarthrosis joints. Amphithrosis joints, like in the interosseous membrane. I don't write very clear here, but that's okay. That's between the radius and the ulna, or the tibia and the fibula. You got slight movement between there. And a free movable joint, TMJ, elbow, shoulder, knee. Those are all freely movable joints. Okay, so everybody understand, you need to understand the difference between synarthrosis, amphithrosis, and diarthrosis. These three terms are important. Okay, synarthrosis are immovable joint. One of them is the sutures, like we just said, found only in the skull, where two bones actually fuse together. Okay. Bones are interlocked together. They got like an appearance, like a puzzle shape, and they lock in together and fit into each other. Okay. You have a gomphosis joint. Gomphosis is like the joint that holds the teeth into the alveolar process of the mandible or the maxilla. Okay. That's an immovable joint. The periodontal ligament, the teeth are not fused to bone. Okay, teeth are attached to the bone in the socket, the alveolar socket, by the periodontal ligament. These are little fibers that connect the teeth. Okay, so teeth aren't in solid bone. That's why they can have. That's why they have a joint between them. Okay, you have synchondrosis, which is a joint with an epiphysis of the bone. It binds the diaphysis to the epiphysis. Remember, the diaphysis was the shaft of the long bone. The epiphysis was the end of the long bone. Between those was the metaphysis. The metaphysis would join those two together. That's a synchondrosis joint. That's their growth plate. That's slightly movable. And synostosis. I'm sorry, that's immovable, I'm sorry. So sutures, gomphosis, synchondrosis, and synostosis are immovable joints. The synostosis is a joint between two fused bones, like the coccyx. Okay? Your coccyx, your sacrum is 5 fused bones. Your coccyx is 3 to 5 fused bones in the vertebrae, which we talked about. Okay? So those are 4 examples of synarthrosis, immovable joints. Okay, and here's a category of it. This is your suture line. This is your gomphosis, teeth in the outer process, synchondrosis, and your synostosis. Okay, we'll get to examples of the other ones right here too. Amphiarthrosis. Amphiarthrosis is slightly movable. Ligaments that connect 2 bones, like between the radius and the ulna, and between the tibia and the fibula. Those are syndesmosis. They're examples of amphiarthrosis joints. The symphysis is a slightly movable joint, like the symphysis pubic, between the pubic bones of the 2 coxal bones. Okay? That's where the baby comes down the birth canal, and the pubic symphysis allows it to expand and to move. It's a slightly movable joint and allows the baby to come out during childbirth. Okay? Here's the interosseous membrane between the radius and the ulna. Again, slightly movable, not freely movable. And here's the pubic symphysis. Okay? During childbirth, that allows that to expand. This is your ilium. This is your pubis, and this is your ischium. 3 bones that make your hip bone right there. Okay? And the pubic symphysis is a slightly movable joint that's cartilaginous pad, which allows the pubic angle or the pubic opening to expand during childbirth when pressure is put on it. Diarthrosis. Diarthrosis are your freely movable joints. Okay? They're also called synovial joints. They're filled with synovial fluid. Okay? Typically found at the ends of long bones, like at the end of the humerus, end of the femur bone, okay? End of the scapula, with the beginning of the proximal end of the humerus bone. Examples of diarthrosis are your shoulder joint, okay? Pectoral girdle, your elbow joint, your hip joint, and your knee joint. Those are all freely movable joints. Okay? All synovial joints have 6 basic characteristics. Okay? So every synovial joint is going to be 6 common characteristics. There's 6 common characteristics. They're going to have a joint capsule, which surrounds it. They're going to have articular cartilage, which allows the bones in the joint to move freely past one another so they don't bind up. The articular cartilage allows it to avoid bone-to-bone contact. Okay? You're going to fill it with synovial fluid. Again, that's going to allow for the joints to move more freely in a liquid environment. You have a synovial membrane, which surrounds, that's just inside the joint capsule. You have accessory structures inside the joint, like cartilage, ligaments, tendons, bursa. What's a bursa? A bursa, by definition, is a fluid. Perfect. You got it. It's a fluid-filled sac. That's what a bursa is. When it gets inflamed, that's characterized as bursitis. You also have sensory nerves and blood vessels. So all synovial joints have blood vessels. They're not like cartilaginous joints. Cartilage does not have blood vessels. It's avascular. Synovial joints are vascular. They have nerves, sensory nerves, and they have blood vessels in them. So those are your 6 basic characteristics of a synovial joint. Okay, and here's a synovial joint. This is the bone. You have the medullary cavity, this is the inside. You have spongy bone, and the periosteum is the outer lining of the bone, which you talked about. Okay, this is your joint capsule. You can see the joint capsule running around the outside here that surrounds your joint. You have the synovial membrane, which is the inner portion, okay, which is in contact with the synovial fluid. You have the articular cartilage. This is articular cartilage. You can see it's a pad that sits on the end of the bone. That's what prevents bone-to-bone contact and the grinding and the destruction of bone in the joint. These are articular cartilage. Okay, joint cavity. The joint cavity containing synovial fluid that allows the free motion of the joint to flow freely. Okay, synovial fluid allows everything to move without friction, without binding up. Then you can see your compact bone here. Compact bone is the outside of the bone. Spongy bone was inside. Is that all making sense? Perfect. All right, this is the knee. Again, we can look at the different structures here. Existing structure of the knee joint. You have bursa. We said a bursa was a fluid-filled sac. And when that gets inflamed and causes pain in the knee joint, when you see a patient comes in, that's bursitis, when the bursa gets inflamed and causes pain. You have a fat pad. Fat acts as insulation. Okay? Insulation to the joint. Okay? You have a meniscus. Meniscus is a tissue that runs between the 2 articular cartilages on both sides. Okay? You have ligaments that are extended to the joint. You have an extracapsular ligament, which extends from the tibia up until the patella. And you have an intracapsular ligament, which is your cruciate ligament, your PCL and your ACL. Okay, those are your cruciate ligaments. You have the quadricep tendon. This is your quadricep muscle comes out and attaches to the kneecap, the patella. This is the patella. This is your kneecap right here. Doesn't connect to any of the other bones. You have your joint capsule, which we talked about. You have your synovial on the outside, your synovial membrane on the inside, and again, you can see the articular cartilage surrounding each end of the long bone to prevent bone-to-bone contact. So everything's designed to allow those bones to freely move so you don't bind up. Okay? All this is designed to have free motion of range of those bones going past one another. Okay? So joints can also be classified in their histological structure. You have a bony fusion, which you have a fibrous joint, you have a cartilaginous joint, and a synovial joint. Okay, bony fusion is like fusion of front of bone. When one bone fuses from two sides during embryological development. Okay, the bone comes as a right and left part and fuses together to make one bone. That's like the frontal bone. You can have a fibrous joint, like your skull sutures, that come together and then eventually form a bone-to-bone contact. You know, a cartilaginous joint, like your pubic symphysis, which is not a slight movement. And you have the synovial joint. It's like a ball and socket or a hinge joint, which allows a lot of free motion. Synovial fluid. Okay, synovial fluid, which fills synovial joints. TMJ, your elbow, your shoulder, your hip, your knee, all that. It lubricates the surfaces of the articular cartilages and reduces friction. Okay, that's what its main thing is, to reduce friction. You still, my computer just flicked out. You still see the picture, right? Everybody still see my slides?
Yes. Yeah.
Okay. My computer just went off on it, but as long as you guys see it, we're good. I'm not going to worry about it. All right. So nourishes the chondrocytes, which produce your cartilage. Entering and exiting the articular cartilage due to the forces acting on the joint as the joint moves. And it acts as a shock absorber. Okay? If fluid is in there when present, when you slam that joint together, the fluid is going to help insulate those two bones from hitting into each other. So that's what synovial fluid does. Accessory structures are there. Okay, you have a meniscus. Menisci is plural, where you have both sides. It's a thin fibrous cartilage that's between the surfaces of the joint. So between the articular cartilage of both ends of the joint, you have a meniscus, or menisci is plural. Okay, the meniscus just simply separates those joints and helps them to move between each other. Ligaments. Ligaments connect bone to bone. Tendons connect muscle to bone. Aponeuroses, we don't have that on here, but aponeuroses, that connects muscle to muscle. So 3 different types of connections. You have your ligaments, which connect your bone to bone. You have your tendons, which connects muscle to bone. And you have your aponeuroses, which connects muscle to muscle. And we'll go through all that too. Okay, so there's 3 connections between the bones and muscle. The bursa was our fluid-filled sac. Bursitis is when that bursa becomes inflamed and it becomes painful for the patient. Usually shoulder, elbow, or hip patients, we have bursitis. Okay. Strength versus mobility. A highly movable joint is not a strong joint, a diarthrosis. If the joint is freely movable, you can damage it. You can it's much easier to damage your knee or your shoulder or your elbow than it is to damage a joint in your skull that are fused together. The stronger the joint is, the less movable it is. The more movable the joint is, the weaker it is, because it has mobility to it. So a fairly immobile joint is a very strong joint, like a synarthrosis. Limited mobility decreases the chance of injuring that joint, which makes sense, right? If it doesn't move, you're not going to injure it. If it moves around, there's a chance of injuring it. Okay. There's different types of movement of your joints. Okay. There's linear movements, straight line, angular movements, circumduction, which is circular movements, circumduction movement, rotation, and special movements. There's many of those. We got special movements. Linear movements. Linear movements is when 2 bones glide past one another, like the carpal bones in your hand, the tarsal bones in your foot. Okay, those bones can glide past one another. The clavicle, your collarbone, and your sternum. There's a joint in here, and they can glide past one another. Okay, that's linear movement. They move along a straight line. Okay, so they'll be able to slide straight back across each other. You also have angular movement, where you have abduction and adduction and flexion and extension. You do need to know those terms, okay? Abduction is to move something away from the midline. So if you're taking your arm and your arm's by your side and you move it out like this, and I can't see a whole about it, that's abduction. So abduction goes from your midline away from the midline. That's abduction, A-B-D. Adduction is to bring it back towards the midline. So when you bring a limb away from the midline, that's abduction. When you take a limb and bring it back towards the midline, that's adduction. Flexion. Flexion is decreasing the angles between two bones. Okay, so if your arm's out straight and you take your bicep and you bring it in, that's flexion because you're decreasing this angle between the two bones. When you take this and you extend it out, that's extension. Extension increases this angle between the two bones. Okay, so you got abduction, adduction, you got flexion, and you got extension. Okay, so this is abduction. You're bringing your arm away from the midline. This is adduction, bringing it back towards the midline. So abduction and adduction. Okay, flexing. Flexing decreases the angle. Flexing decreases the angle. Okay, flexing decreases this angle right here. Extension increases this angle. You'd extend this arm, this would increase. And take your head and go back. You increase the angle between your chin and your thorax. Okay, so flexing, decreasing between two bones. Extension, increasing angle between the two bones. Rotational movement. You have pronation and supination. Supination. Okay, pronation is down. Supination brings it up. Circumduction movement. Moving the joints in a circular manner, like in a cone shape. Like you take your elbow and just rotate it in a circle, 360 degrees. Okay, that's circumduction movement. Okay, rotation, external rotation, pronation, supination, we did all that. Okay, synovial joints can be classified. Synovial joints, remember, have synovial fluid, they have articular membrane, they have 6 common things in 6 factors in common with each other. You can have a gliding joint, like your clavicle and your manubrium. Those joints can glide. You pivot joint, like between C1 and C2. You have a saddle joint. Okay, and we'll go through examples of each of these two, which is a carpal metacarpal joint. You have carpal and metacarpal joint. You can have a hinge joint, like your elbow and your knees. You can have an ellipsoid joint, like your metacarpal phalangeal joints of your fingers. Okay? Or you have a ball and socket joint, like your shoulder and your hips, where you can have free rotation. Okay? This is a gliding joint. You can see this is a joint here, and you can see your movement is in a gliding path on one plane, and it can glide on this plane in one dimension. That's a gliding joint, like your clavicle and your manubrium. Okay, you have a pivot joint, okay, where one is able to spin around the other, where the axis in the atlas allows it to pivot so your head can make the no motion. It allows you to pivot on both the axis and the axis and spin along that joint. That's a pivot joint. Okay? You have a saddle joint, which is just like it sounds. You have a saddle that fits over a bridge, and it can rotate along that pivot, along that saddle. Okay? It can swing or rotate around it, like the metacarpal bones of your thumb. You're able to pivot your thumb and move it from side to side along that saddle joint. Okay? You can have a hinge joint, which is just like it sounds. It's just a hinge, like your elbow or your knee. You can take it and move it straight and hinge it back and forth. You can have an ellipsoid joint. Ellipsoid joint is a circular motion, and this fits in like a mortar and pestle, and this allows you to rotate inside this elliptical shape and allows greater movement of all directions around. And you can have a ball and socket joint. That's the most flexible joint you can have. That's your shoulder joints and your hip joints. Okay? Allows complete rotation in all directions. Okay? You see how it just fits in just like a ball fits into a socket. All right, who's paying attention? Okay, this is your hip joint. your hip joint or hip bone, or your pelvic bone. What's number 1 pointing to? What's this bone right here?
Ilium?
Yeah, the ilium.
What's your ilium? What's this joint right here?
The pubis.
Bone. Perfect. And this bone right here?
Ischium?
Ischium. So the ilium, the pubic, and the ischium. What is this joint called right here?
The pubic symphysis.
Symphysis.
Pubic symphysis. And it's an example of a movable joint, not freely movable, but a limited movable joint. Okay, because this joint allows us to expand, pubic symphysis, it expands during childbirth and allows the opening of this canal to increase. The temporomandibular joint. Okay, one of my pet peeves, everybody has pet peeves, is patients that come in and say, I have TMJ. I look at them and go, yes. You also have elbow, you have hip, you have knee. I mean, you have TMJ, yes. TMJ is not a problem. Temporomandibular joint, you have one, okay? TMJ dysfunction, that's a problem. All pet patients comes, I have TMJ. I go, yes, you have TMJ, okay? So the temporomandibular joint consists of a condylar process. Everything's what the condyle is, right? The head, the condyle, the corner process, the mandibular arch, mandibular arch. Process of the mandible is the mandibular fossa of the temporal bone. We talked about that in the lab last time. So the condyle of the mandible articulates to the mandibular fossa of the temporal bone. That's where concussions occur. That's where the joint is flexible. That's where TMJ dysfunction occurs. Okay. You have the stylomandibular ligament. Stylomandibular ligament connects the tip of the spinous processes together. The lateral ligament in the TMJ connects the zygomatic arch to the mandibular condyle. And the sphenomandibular ligament connects the sphenoid spine to the ramus of the mandible. So that's how the joint all connects to the bone and allows the mandible to sling open and also deviate sideways. Okay? Most of them are supposed to be hinged, but it can have some sideways motion to it. Okay, so here's our picture. This is our zygomatic arch. We all saw how that extends out from the lab last time. This is the zygomatic bone. Okay, so this is the temporal extension. This is the zygomatic extension of the temporal bone. And this is the zygomatic bone right here. And it connects to the maxilla over here. Okay, you have your coronoid process. Remember this part of the TMJ, of the mandible. This is your coronoid process. This is your condyle right here that's wrapped up in this joint. Okay, so there's your coronoid process. You have your external acoustic meatus, which is the opening to your ear canal. You have your articular capsule. Remember, the articular capsule surrounds all synovial joints on the outside. You have the mastoid process, which sits just posterior to the external acoustic meatus. You have the styloid process, which is your hook that hangs down. Okay. You have the lateral ligament, which connects the side of the mandible of your condyle to the zygomatic bone. Right? That was the lateral. You have the sphenomandibular ligament, which connects the mandible to the sphenoid bone. You see the sphenoid bone back underneath here. Remember, the sphenoid bone is our butterfly-shaped bone in the skull. Okay. You have your stylomandibular ligament next to the mandible to your styloid process, which is this ligament right here. And you have the ramus of the mandible. What's this point called on the mandible? I'll draw it like this. The angle, right? The angle of the mandible. And this is the body of the mandible. Cool. All right. So now you dissect away the articular, what are you doing, pup? You came with me to the office. All right, so you have your articular surface mandibular fossa. Remember, this is the temporal bone up here. And you have the articular surface of which is going over the ending bone of the mandibular fossa. Okay. You have your articular disc, which is the disc between the two articular processes of bone, between the mandible and the temporal bone. You have your condylar process, which is the bone of the mandible. You have the neck of the mandible. your articular capsule, which you cut away here. Whoops, come back. Go backwards. There we go. Coronoid process, mandibular notch, and your zygomatic bone cut away here. All right. So we talked about vertebrae of the last lab too. The adjacent vertebrae articulate their superior and inferior articular processes. Superior processes articulate with the vertebrae above. Inferior articular processes articulate with the vertebrae below. Adjacent vertebrae are separated by intervertebral discs. Intervertebral discs are not synovial joints. There is no synovial fluid in those discs. They're cartilaginous pads. There is no fluid in them. There's cartilaginous pads that allow cushioning between the vertebrae. Intervertebral discs are pads of cartilage between vertebral bodies of adjacent vertebrae. Okay? The vertebrae can move. We're not as flexible as hip bones and shoulder joints and things like that, but you do have movement. You have anterior flexin, which is bending forward. You decrease the angle, so it's flexing. So you can flex your body forward. You can flex your body backwards, bend backwards. That's extension. Okay? You can go to the side. You can twist your body right and left sides. That's bending to one side, to the right or left. And you have rotation, where you can twist your vertebrae. In a twisting motion, that's rotation. So 4 vertebral movements: anterior flexion, extension, the exact opposite, lateral, side to side, and rotation. Okay, the shoulder complex. The shoulder complex consists of 3 bones, which we talked about last time in the lab. It consists of your clavicle, your collarbone. It consists of your scapula, and it consists of the humerus, the bone of the upper arm. Okay, here's your scapula, your clavicle, and then your humerus. All make up the shoulder joint. And we talked about the acromion process of the scapula, the lesser tuberosity, the greater tuberosity, we have muscle attachments. Okay. Sternoclavicular joint. Sternoclavicular joint is where the sternum connects to the clavicle or collarbone. Connects the clavicle to the manubrium of the sternum. Okay. Has anterior and posterior ligaments that hold it together. There's an interclavicular ligament which connects the 2 clavicles, right and left, that runs across the midline here. And there's a costoclavicular ligament, which extends from the clavicle to your first rib. Okay. There's your interclavicular ligament. This connects the 2 clavicles. Okay. This is the anterior sternoclavicular ligament, connects the sternum to the manubrium. Connects the clavicle to the manubrium of the sternum. And your costoclavicular ligament connects the clavicle to the first rib as it comes across here. And this is the body of the sternum. This is the manubrium of the sternum right here. Okay. Elbow joint. Oh boy. Elbow joint connects the lateral epicondyle of the humerus to the radius. You have an ulnar collateral ligament. Connects the medial epicondyle to the humerus of the ulna. Humerus to the ulna, sorry. And an annular ligament, which connects the head of the radius to the ulna. I'll show you where all those are. This is on the right side, looking on the lateral side of the elbow joint. This is your right collateral ligament. On the right side, it's the radial collateral ligament, connects the radius to the humerus, and your annular ligament, okay, coming this direction, connecting the ulna. Okay, you got your ulnar collateral ligament. You can see it feeding here, here, and here.
That's the one that they do Tommy John surgery on, right?
And your, what's that?
That's the one they do the Tommy John surgery on, right? The UCL?
UCL, yeah, that's UCL. Yep. That's a difficult surgery because you can see the ligament extends in 3 different directions too at the same time. So it is a hard surgery to do. But that's your UCL surgery on your elbow joint right there. And then you have your annular ligament right here, going around to the radius, ulnar to the radius. And this is what it looks like on the cadaver. This is your UCL, your ulnar collateral ligament. And you can see doing surgery on this, you can see how it's connected here, and then it connects in a tripod back behind it too. Okay. Joints of the hand. You have the carpo, metacarpal junction, where your carpal bones meet your metacarpal bones. Okay. You have your intercarpal joints, connects one carpal bone to another. Your metacarpal phalange joint connects the metacarpals to the proximal phalanges, and your interphalanges joint between the proximal, middle, and distal phalanges. Okay. Now, which joint only has a proximal and a distal phalanges? Which one of the digits?
Oh,
The pallets, right? The pallets is your big thumb, is your thumb. That only has a proximal and a distal phalange, only two. All the other digits have the three joints, the proximal, middle, and distal. Okay. So here's your intercarpal joints between all the carpal bones. Here's your carpal bones. So between those bones, you have intercarpal joints. You have the carpometacarpal joint, which is between the carpal bone, metacarpal bones. Here's your metacarpal bones. And it's this junction right here. Okay. You have the metacarpal phalange joints, and then the interphalange joints. 3 in every digit, except for the phalanx, which has 2. Okay. The hip joint. Hip joint has the iliofemoral ligament, has a pubofemoral ligament, has the ischiofemoral ligament. Okay, all those connect the femur to the acetabular rim of the pelvic bone. Transverse acetabular ligament connects the femur to the inferior acetabular rim. And the ligament of the femur connects the fovea capitis to the transverse acetabular ligament. You can see some of those right here. This is the iliofemoral ligament. Okay, and your ischiofemoral ligament. These are these two sections right here. This is your iliofemoral ligament here. Again, connecting to the femur bone, next to the greater trochanter, and the pubofemoral ligament, connecting the pubic bone to the head of the femur. If you take a side view of it, dissect the side of it, you see the ligaments of the femoral head, where they're situated, where they attach, and you see the transverse acetabular ligament to the side here just below that, just inferior to it. That's how the two connect into the head of the femur bone. Okay. In the knee joint has supporting ligaments in there, help hold the knee in place. You have the tibial collateral ligament, which was your medial collateral ligament, your fibular collateral ligament, which was your lateral collateral ligament. You have your patellar ligament, patellar retinaculum, popliteal ligaments, the ACL, anterior cruciate ligament, and the PCL, the posterior cruciate ligament. Okay, the ACL, a lot of people tear during sports activities as the knee twists. And you'll see how it connects. Oops, where'd I go? Going backwards. Okay. You have the tibial collateral ligament also is a supporting ligament. Connects the medium epicondyle of the femur to the tibia. The fibula collateral ligament connects the lateral epicondyle of the femur to the fibula. And the patellar ligament connects the tibial tuberosity of the patella. It's extension of the rectus femoris tendon that connects into the femur bone. Okay, look at there's a picture of all these in just a second here too. In the knee, you have the popliteal ligament, which is a Y-shaped ligament. Okay, connects the femur to the head of the tibia and the head of the fibula. The ACL, which causes a lot of damage, the sports injury. Connects the tibia to the lateral edge of the intercondyle fossa of the femur because it runs at an angle through the knee. And when the knee twists, that's the ligament that gets torn, is the anterior cruciate ligament, the ACL. The posterior cruciate ligament connects the tibia to the medial edge of the intercondyle fossa of the femur bone. And this is what they look like on the cadaver. You can have your medial condyle, your lateral condyle. Okay, here's your ACL. Comes down here and dives down below that and kind of twists around and comes around back into here. It comes around in the back behind that. Okay, so you have a twisting motion to your knee. That's the one that gets ripped and gets torn. Okay, you have the tibial collateral ligament connects to the tibia, and the posterior cruciate ligament comes around across right from the tibia to the femur bone. But the ACL is the one that dives down behind it and wraps around behind and connects up behind the femur. So any kind of twisting motion, this is the one that gets damaged, the ACL. Okay, here's your patella. This is your kneecap. It's a free-floating bone. You have the median patellar retinaculum to the side. You have the patellar ligament. Connects from the tibia right up to the patella bone. And you have the medial patellar ligament and the lateral patellar retinaculum on the sides. And the patellar ligament right dead center. So the skeleton muscles are structurally and functionally interdependent. Okay, they develop on their own and they come together and they work together to form movement, but they're structurally and they function independent of one another.